Hello and welcome to this Health Foundation webinar on complex public health challenges and local action. How does local government tackle complexity? I'm delighted to be here today and it's great that so many of you have been able to join us. My name is Jane Landon and I'm a Senior Policy Fellow at the Health Foundation and I'll be chairing the session today. I'd like now to introduce our two speakers on this webinar. On my right, Dr. Harry Rutter, who is Clinical Research Fellow at the London School of Hygiene and Tropical Medicine. Hi, Harry.
Hi.
And on my left, Professor Jim McManus, who is Director of Public Health at Hertfordshire County Council. Warm welcome, Jim.
Thank you. Hello.
This is our first webinar on a topic which is part of our Healthy Lives work here at the Health Foundation. Our Healthy Lives strategy aims to improve health, looking beyond the healthcare system by supporting cross-sectoral action on the social determinants of health. One of the major challenges for public health is how do we generate evidence that is useful to decision makers and that reflects the multifactorial nature of the health issues that we face today, issues such as obesity, such as poor mental health, and such as health inequalities. Also, how do we understand the factors which drive these different problems? As part of the Healthy Life strategy, we are pleased to be working with Harry on a programme of work which aims to help overcome some of the research challenges and to support the use of different methodologies that we need for population level as well as individual level interventions. We'll hear a bit more from Harry about that in a moment. So please do send us your questions during the presentations. You can do that by typing them into the box on the left-hand side of your screen. We'll be monitoring those questions over the course of the presentations as they come in, and we'll start the question and answer session once we have heard from both of our speakers. So first we're going to hear from Harry, who is going to explain how we can think about public health challenges in terms of complex systems, to develop new approaches to both the design and the evaluation of population-level interventions that can improve public health. So over to you, Harry.
Thanks very much, Jane. So my talk today is, in just 20 minutes, going to try and start to explore some of the problems that we face in public health that traditional approaches have hit a bit of a stumbling block at dealing with, and start to explore some of the ways in which a complex systems thinking approach might be able to help us get over some of those challenges and then lead into practical responses to them that Jim's going to talk about some more. We hear a lot about evidence when we're talking about health, and rightly so. But sometimes the evidence that we have is less helpful than it might be. And one of the metaphors I've used for this is to come up with this idea of something that I've called a dangerous olive of evidence. So if all of you watching this now were to write down on a piece of paper your top 3 things that you believe would make a difference to reducing obesity, things for which we may not have firm evidence, we may not have a solid trial or a study, anything published in a journal, but good ideas, things that make sense. That's the stuff that sits in the flesh of this olive. The olive is stuffed with a pepper, and the pepper contains the subset of those interventions that you've all written down, for which we do in fact have some pretty robust evidence that they work. That pepper is then stuffed with a very, very small piece of garlic, which is the subset of those interventions for which we have evidence of effectiveness, for which we also have evidence of cost effectiveness. But as I've said, this is a dangerous olive, and there are concerns, I think, about the kinds of things that sit within the pepper and the garlic, the kinds of interventions for which we have evidence of effectiveness, and I'd like to try and explain why. One way of thinking about obesity is that we need a huge range of actions at all levels of society, throughout the life course, at multiple different levels of the system, from individual level treatments such as bariatric surgery, all the way up to reform of the Common Agricultural Policy. It's like building a wall of sandbags against a flood. But all too often in our research, what we do is we take one sandbag out from that wall, and we might even put it in a randomised controlled trial, and we assess it to see if it stops the whole flood. Does this intervention on its own have an effect on the distal outcome of obesity? In many cases, we find that it doesn't. But we're judging those interventions on the wrong criteria. You wouldn't expect any one sandbag to stop a flood. We should test a sandbag in terms of its effectiveness at being a sandbag, not as an entire wall. So if we look at this diagram, which is adapted from one that Boyd Swinburne used in a 2011 Lancet paper on obesity, there's a range of interventions that we can put into place. On the right-hand side, we've got those individual level interventions, such as drugs or surgery. And on the left-hand side, we've got very upstream policy interventions, agricultural policy, taxes on sugar, fat, and so on. At its most extreme, perhaps, a really significant tax on carbon emissions, which would affect the ways in which we move around, the kinds of foods that get produced, and so on. And in the middle, we have, in general, the kinds of things that relate to our local environment, the numbers of fast food outlets on our high streets, the provision of cycle lanes or high-quality infrastructure for walking in our towns and cities. So very, very broadly, in this diagram, what we've got is on the left-hand side, the kinds of interventions and actions that can be taken by national government. Around the middle, we have the kinds of interventions and actions that can be taken by local or regional government. And on the right-hand side, we have actions for the health service and also for individuals. And there's a wedge across the bottom there that says population effect and political difficulty. And what we find is that the individual level interventions can be extremely effective in any one individual. But at population effect, they tend not to be practical at shifting the population. Bariatric surgery, surgery for obesity, is a very, very effective intervention in the right individuals. But we've got around 1.5 million people with a body mass index over 40 in this country. Very, very rough measure of need. I'm not for a moment saying that all those people should have surgery, but as a very rough indication, we've got about 1.5 million people who might benefit. But we do something like 6,000 or 7,000 of those operations a year. Great intervention in the right individual, but it's not a population level response. On the left-hand side of the diagram, we've got big picture population level actions. Agricultural policy, the kinds of things that determine the amount of sugar and fat flowing into our food system. Actions to shift that are politically extremely difficult to do, but they could have big picture impacts on the distribution of body weight across society. And then I've added 3 more little wedges across the bottom, all skewed over to the right. Evidence base is skewed towards the individual level. Public, political and media discourse is also skewed towards the individual. And as a result, political mandate is skewed towards the individual. So this is why the olive that I showed you earlier is dangerous, because the kinds of things that sit within the pepper and the garlic are the kinds of things that sit on the right-hand side of this diagram. It's not to say that they're not helpful. They are. They're an important part of the picture. But if that's all we do, and we ignore the more upstream things over to the left-hand side, we're missing some of the potentially most effective and most powerful interventions. There's another aspect to this, which comes from an academic who was at my institution, the London School of Hygiene, called Geoffrey Rose. And Rose talked about the difference between the population level interventions and the targeted interventions in high-risk populations. And one of the consequences of using words like obesity is that we tend to think about people at the far end of the population distribution, people who are perhaps candidates, possibly, for surgery. But what Rose pointed out is that many of the interventions that we could be doing to tackle population level problems don't just involve targeting specific individuals with big effect interventions such as surgery. They may be about making very, very small changes so small that you couldn't actually detect their impact in any one individual. But if you aggregate them up across the entire population, you shift the distribution across that population over to the left. So we could reduce everyone's weight by a small amount. You might not even be able to pick that up at individual level, but across the population, you would have improvements in health across large numbers of people. So what's this got to do with complexity? And I think before that question can be answered, it's important to grasp what we mean by complexity. Because often I think the idea of things that are very complicated is confused with things that are complex. Now, there are lots and lots of different ways of defining these words, but one of the ways that I find really helpful is to use this analogy of a space rocket, a Saturn V rocket. This is an incredibly complicated piece of equipment, incredibly detailed, thousands and thousands of parts to it. It would take a very long time to build one, but if you know what you're doing, you can put 3 people into that little cone at the top, send it to the moon, and whatever it is, 5 or 6 days later, you know exactly where to pick those people up from in the ocean. So it's a hugely complicated thing, but it is predictable, it is controllable. You press a button to launch it, and 5 or 6 days later, you know to within a minute or two and to within a few hundred meters where it's going to end up. Geopolitical relationships in the Middle East, however, are a rather different category of problem. And this is what a complex problem looks like. If you intervene in any one part of this, what you find is that there are unpredictable effects. There are linkages across this entire system. This is not a system or problem that one can solve, because a complex problem in general isn't something that one can solve. A complex problem is something that one can intervene in to create a reconfiguration and lead to changes and potentially a different set of outcomes. But all too often, we conceptualize problems that look like this as if they look like the space rocket. We even in health services talk about the delivery chain, as if there was a link going to a link, going to a link, going to a link, when in fact we have a whole load of interacting elements that influence one another, and things change as things move. So at the heart of grappling with complexity is understanding that we don't necessarily have these kind of straight, direct, linear relations between cause and effect that much of our scientific thinking has taught us to think about. And I've been involved in some work in a city recently where we've looked at using this approach for thinking about physical activity. We've mapped out the physical activity system, and here is a first stab at it. We weren't for a moment pretending that this was a definitive definition of all the things that sit within physical activity in a local authority, but it was a tool, a way of encapsulating some of the important things that can be done at local authority level to promote increased activity across the population. And very broadly, on the right-hand side of this diagram, we've got individual level actions, providing people with information, social marketing schemes and so on. On the left-hand side, we've got more structural things, cycle lanes and so on and so forth. And in the middle, we've got the kinds of things that get measured, levels of walking and cycling, and so on and so forth. And we worked with people in this local authority, and we said, draw on this map the kinds of things that you think would be really helpful to do to increase the level of walking and cycling and physical activity in general. And they highlighted a whole load of activities in that structural area on the left-hand side. We then got them to map out the kinds of things that they were currently focusing on, and that was the kinds of things that were on the right-hand side. So merely by mapping out the system and working with a group of stakeholders to examine what bits of the system were being acted on and what bits were not being acted on, it was possible to identify potential areas for changing activity, for bringing new activity in, and so forth. And we used it much more than this. We looked at data that could be measured, for example, the kinds of things that were already being collected and other things that one might collect over time to identify changes within this system. And time, I think, is a really important dimension that we've often lost sight of in public health. When we're thinking to come back to childhood obesity, when we're thinking about how we act to tackle childhood obesity, many of the things that we focus on initially deal with, understandably and appropriately, the problems of health, the health problems that arise during childhood. Of course, one wants to make sure that children who have a weight problem are not subject to stigma or bullying or physical health problems. And if we go back to the olive, what we find is that there are some areas in which we do have some evidence, the things that sit within the pepper and the garlic, that relate to this domain. The next thing we look at is the idea that obesity in childhood tracks into adulthood. If you're overweight as a child and as an adolescent, it's more likely that you will be overweight as you go into adult life. So of course, reducing the weight status of children during childhood is a helpful thing to do. It reduces the likelihood of that long-term gain. But what we all too rarely look at is the kinds of interventions that might be introduced in childhood that could affect not just what happens to that child during childhood or their weight status at the end of childhood, but actions that might affect their behaviour across the life course. One way of thinking about this is to use the example of a walking school bus. And my kids used to do a walking school bus. You drop them a bit of a way from the school, maybe half a mile or so. They'd walk in a group wearing a high-vis tabard so that they're safe on the roads, and they might burn an extra 20 or 30 calories a day. At one level, one might say, 20 or 30 calories a day, big deal. What's this really going to do? Well, actually, I think if you can find 5, 6 or 10 other things where those kids burn 20 or 30 other calories a day, that's 200 or 300 calories, and that really is a big deal. So I don't think it should be dismissed merely on the fact that the energy expenditure of this intervention isn't so much. But my sense is that some of the more important impacts of something like a walking school bus may be wider system effects. The fact that if you have a cohort of children who get used to walking to school every day, they get used to the idea of walking, whatever the weather. Snow, rain, windy, they can just get used to it. It normalises walking. You might get a cohort of parents who are particularly keen to make sure that those streets are safe for their children to walk on. They might vote for different politicians, people who want safer streets, lower speeds, and so on and so forth. And you might get a cohort of children for whom, because walking has been normalised, they, not all of them, but a proportion of them, might be more likely to walk during other aspects of their life as they get older and older. And if we were to design this intervention thinking about that, we might not want to put them in high visibility tabards, because normal people don't wear high vis tabards to go for a walk. We might want to normalise walking rather than denormalise it through the understandable safety conscious approach that we take. But it might actually be counterproductive if we're trying to think about the long-term system effects of this kind of intervention. So if we come back to the Swinburne diagram I used earlier, that shows the range of actions that can be taken from upstream to downstream, what we're aiming for with this work is not to stop the kinds of interventions at individual level on the right, but actually just to rebalance the distribution. Keep doing the individual level stuff, but let's move upstream. Let's think about the ways in which we can promote more and bigger changes to affect the environments in which people live in equitable, fair ways that help to reduce inequalities. And the particular focus of the work that I'm involved in with Jane and others at the Health Foundation is particularly to look at the bar there that relates to the evidence base. But I'm not for a moment pretending that that's the only bit of this that needs to be done. There is a whole host of other things that need to be done, including the practical actions at local level that Jim will be talking about in a minute. But the particular focus we've had here is to think about the role of academia, the role of research in rebalancing that evidence base. So we move away from producing evidence on the things that are easiest to test, where you can do a randomized controlled trial with a neat cohort of people over 3 to 5 years and come up with some results, and think more deeply about ways in which we can generate messier evidence that moves upstream. One of the factors in this that has come out from some work that I did with colleagues from NICE was to look at the kind of evidence that's required to make a decision. because the real world out there is having decisions made all the time. But all too often in public health, I think, we say we need to wait until we've got good enough evidence, high quality evidence to be able to act. And I see this as a bit like the difference between the civil and the criminal law burden of proof. All too often we say we need to wait for a Cochrane review or something like that. We're demanding a criminal burden beyond reasonable doubt. When actually, if a decision is going to be made anyway, perhaps we should be looking at a civil burden of proof, the balance of probabilities on either side of a decision. So not just what's the evidence for what I want to do, what's the evidence for what the other people want to do? What's the balance here? And it may be rather poor quality on both sides, but is it good enough to help us make a decision? And all this has led to some work that a group of colleagues and I have been doing. We've had a paper published over the summer. We're now trying to develop this further. We're writing some more academic work and putting in research proposals where we're building these themes in. But unless this has practical application, I'm not very interested in continuing it. So what we really need to do now is move from this theoretical argument and making the case to turning this into practical action. There's a set of conclusions from what I've been saying, but I guess of these, I think there are 2 or 3 things I'd pull out. One is really to emphasize this point that our interventions within complex systems all too often are, we think about them as like hitting a nail with a hammer, when actually what we're doing is introducing shifts, perturbations, changes within a system. And some of the consequences will be unintended and perhaps unwanted, and we need to be prepared for that. I'm also well aware that much of the talk about complexity can put people off. And sometimes I think we should be keeping these, it's a bit like the difference between what's backstage and what's front of house in a theatre. We can have the messy stuff backstage, but let's distill that into something that's a bit smarter front of house. And I guess finally, I'd like to come back to the theme of time. Let's stop just looking one step ahead. Let's think about where we really want to be. What's our 20-year vision? How do we translate that into a 5-year strategy to fit a political cycle, for example? And what are the 1 or 2 things we need to do now? So 20-year vision, 5-year strategy, 1-year plan, and they should all be aligned. Thanks very much.
Thank you very much indeed, Harry, particularly for giving us such a clear sense of how we need to understand the complex nature of the public health challenges, but also embrace some of the messier evidence considerations as we try to design and develop interventions and to evaluate what's actually happening on the ground. Okay, so before we carry on, just like to say we're getting some good questions coming in. Please do continue to send in your questions as we hear from our second speaker, Professor Jim McManus, who will be sharing with us his experience about the public health problems that he faces on a day-to-day basis at his local authority and how you and others are currently trying to approach those. Okay, so
Thank you.
hand over to you.
Thank you. Hello, everybody. I'm going to try and talk through some of the practical aspects of how we're trying to do this. The first point I would make is that we're not doing systems in Hertfordshire because I'm doing systems. We're doing systems in Hertfordshire because a number of us are persuaded that this is the approach. So much of what is going to be presented is not my doing, but it's the doing of us as a team and the doing of us with stakeholders. One of the important points I think Harry made for me is the crucial thing about systems approaches is you can use them to elucidate problems where you can intervene. And in fact, I once heard Harry say that the key single thing we need to realise about obesity is there is no key single thing we can do about obesity. There are a number of them. And so bear that in mind as I go through these. I'm going to try and share some practical information and also explore why it's useful to think about these challenges in a systems way, some of the health challenges we face. Now, the system I face every day is very complex, and it's the models that are too simplistic. Complexity is a part and parcel of what local authorities do and has been since they started. We just haven't always conceptualised it in that way. And I think actually public health hasn't always been as much at ease with complexity as it could and should have been throughout the years. The Health Foundation has massive experience in quality improvement work, and I think quality improvement techniques and complexity systems approaches align quite well. I would say that the paradigm of the evidence pyramid actually doesn't handle complexity very well, and Harry has illustrated that extremely well. So some examples are coming. So the organisation I work in and for has over nearly 2,500 statutory responsibilities. We have 1.2 million residents across 37 settlements. They all want their own branch of John Lewis. We have 3 tiers of local government, over 100 partners, and over 537 schools. You can't not do complexity in an environment like that. It just isn't possible. So complexity approaches work much better than linear approaches where we have really messy organisational systems and really big responsibilities. And engineers in local government have been doing this for 60, 70 years. You can't build a road network, and indeed our 3,000 miles of road in Hertfordshire needs a complex approach to maintain it. The first example I want to talk through is about public mental health. So if you look at the graph here, what this graph is telling you is actually that as you go through the life course, the influences on you and your health outcomes vary. In early years, family, daycare, community and school will be much more important than individual workplace and community influences and family influences in later life. What that means is that you need to see public mental health, somebody's resilience, somebody's well-being, as set into a range of complex factors that can impact on them positively or negatively. Psychologists talk about vulnerability and protective factors. These don't exist in nice, neat chains. They exist in complex relationships and systems. So if you're going to do something on public mental health, for example, as I'll show you shortly, you have to take that systems approach. And that's what we're doing in Hertfordshire. So we have about 1,300 workplace champions, but we're also doing work in schools. So that's one area where complexity approaches have really helped us conceptualise we need to intervene across a range of levels. Second area is within that, the needs of LGBTQ young people. So if you start just with strengthening the individual, that isn't going to reduce homophobic bullying, it isn't going to reduce self-harm and suicide attempts by LGBT young people, and it certainly won't reduce the incidence of mental health problems where the school environment or the family environment or the community environment are the problem. So we've conceptualised this as a range of levels. There's some intrapersonal stuff we need to do around resilience, self-worth, physical health, making sure that health professionals understand the needs of our LGBT young people. There's some work that we need to do at the interpersonal level of working on equality, working on behaviour, working on school environments, and then there's the environmental level of policy and systematic training and monitoring and building social norms that are anti-bullying. You need a complex approach for this to work. If you don't take a complex approach, you will miss things and you won't be as effective. Similarly, just to look quickly at tobacco, any tobacco control plan worth its salt works on at least 6 levels. From the biological level of nicotine replacement therapy up to the policy level of smoke-free environments and training. That naturally lends itself to a complexity model. I won't spend more time on this, but you can have a copy of these slides if you like. They'll be on the Health Foundation website later along with this webinar, but they'll also be available on email from me. So how do you work with these complex systems? I think you need to build a framework for yourself. And that framework starts really with a level of questioning. So firstly, systems approaches can help you conceptualize the world that you're trying to influence. That for me is the fundamental starting place. If you can't build a picture of that world and that picture isn't complex enough, then there's not much point starting to do anything. Secondly, you consider the levels of influence of various things. I've talked about biological up to environmental, but you could talk about any level of them. The maps Harry showed were excellent examples of some of the influences. everybody was working on one set of interventions on the right on obesity, but not on the left, which might have been more effective. Then I think you need to consider the evidence paradigm. You don't need gold standard meta-analyses of randomised control trials for everything. In fact, for some things, you'll never get them. We don't have randomised control trials for bridges, but on the whole, they tend to stay up. And then finally, I think you need to refine and adapt this model as you go along. The beauty about systems approaches is it requires you to adapt and refine, and you can do that quite regularly. So what have I learned after 5 years of trying this out? Well, firstly, this actually is a different style of working and influencing and advocating. Systems approaches have helped me to influence and advocate. I can argue, for example, Harry's point about the need to do population level interventions, not just individual level interventions. And one of the great debates we have about health inequalities is, do we address individuals or do we address populations? If you take a stress approach, if all you ever do is strengthen individuals when the organisation they work for is the fundamental problem, you will never solve organisational stress. You need to take a systems approach. Now, most HR professionals understand that, so taking a systems approach and a population approach can work in those environments. The benefit of using systems is that they can really help you articulate why we need a systems approach and why we want to use that. So systems thinking becomes a very strong tool for leadership in your portfolio. It sits alongside other tools and skills. It doesn't replace them. It just becomes something else in your armoury of things you can do. And the key thing here is to be able to be agile in thinking. Using a repertoire of tools, they become your watchwords. So how you apply these is crucial, as well as being able to choose which ones you do, and it's as much an art as it is a science. Becoming comfortable with systems approaches is a leadership task. The whole point of using systems approaches is actually to reflect on the world you're engaged in, while engaged in practice in order to change that world. So that circle of moving from theory to action and reflection and back again, or even a spiral of moving onwards, is a key leadership task. And I think systems approaches lend themselves naturally to being able to do that. So where we are now is an attempt at building a systems approach to prevention in an entire population system. The first thing we're trying to do is attempt to do system-wide prevention. So there's work on family safeguarding, which is preventing and stopping our young people being taken into local authority care or looked after, and we're having some significant success in that. Assistive technology for the other end of the life course. Looking at our asset management, how can we actually use our land and our buildings to build housing that keeps people independent as a form of long-term prevention? Looking at our contractors, what can we do with our contractors to reduce non-communicable diseases, to prevent people becoming ill as they go through their life course? There are a range of things that we want to do. There's a range of things that we've started. We can't do everything, so we've picked 6 or 7 areas, and those are some of them, where we think if we start, we'll have some long-term as well as some short-term effect, illustrating Harry's point about the 3 levels down to the 1-year point plan. We're using systems approaches to understand and prioritise how we act. And actually, as a prioritisation tool, systems approaches have been really helpful for us. The key thing, though, is you need to refine and redevelop this. This brings me, I think, to another key point about symphonic thinking. If you're using systems approaches and are working in a complex system, you need to behave a bit like a conductor, bringing together a range of different instruments and players, all playing different sounds to play together in some form of harmony. Sometimes you need to disrupt that if the system is really dysfunctional, but unless you are working in that approach, using that symphonic approach, you're not going to get the same outcomes you would as if you were using that approach, and more importantly, you won't see any benefits over a very traditional, let's just do what the evidence says we can do, where the evidence takes us beyond reasonable doubt approach. So you either go at this or you don't go at this. You can't be half-hearted. You have to take the plunge. I think the Health Foundation can do a significant number of things here. aligning some of their quality improvement insights and tools can really help you use systems approaches. There's a very good book just published by De Savigny, which is aimed at researchers and academics. It talks about methods for systems and using complex systems, things like network analyses, various other things, really practical tools. Although it's aimed at an academic and research audience, it does have application. By the same token, some of the work that the Health Foundation has done on systems is also very useful, and I advise you to look at their website. So I'm going to finish off with what I call my golden rules. And these are provisional. They're the fruits of 5 years of trying this approach. And there are two sides to it. If you're an academic or researcher or somebody who hasn't worked in a local government environment, don't take a deficit approach. Don't start working with local government by assuming that you know better than they do, because that's a surefire way of winding them up and getting nowhere. Actually, there are riches everywhere, and you can learn from the way they do things as much as they can learn from you. So spend some time in and with local government before we pontificate about how to do it. There is a great danger that public health can be seen as the boffins, and there's a great danger that public health can be seen as a bit sciencey and therefore actually a bit detached from the real world. The key thing is get your sleeves rolled up and get stuck in order to influence the system. Now, if you're in a system, I think my key rules would be use systems as a set of tools to orient your practice, and just take the plunge and draw a diagram of the system you work in and the things you want to achieve. Yesterday I was sitting in a room with a number of our senior police colleagues looking at systems approaches to health, and mental health in particular. And we just started somewhere. It might not have been the right place, but we couldn't find anywhere better to start, so that's where we're going. And it is really as simple as that. Start somewhere, get people on board, and walk before you can run. Do some reading, but do some reading that tries to bridge the theory of systems with the practice of systems application. But I guess there are 3 key points. If you're going to use systems well, use systems to conceptualize what you're doing. The second thing is see it as a leadership tool in a portfolio to help practical change. And the third is refine and adapt. Thank you for listening. My email's there if you want a copy of the slides, and I look forward to your questions.
Thank you very much indeed, Jim. That was fantastic. Really helpful to hear how you have moved from the theory of complex systems to very practical approaches with some examples from your work in mental health and working with people from LGBTQ communities as well.
And some of it's his fault.
Some of it's his fault as well. Okay, so while you've both been speaking, we have had some questions that have been sent through in response to both the presentations. I'd like to start with this question, which has been sent in saying, how can you implement system-wide complex approaches when there are so many immediate crises that take most of the available monies and that need to be managed every day? Shall I perhaps start with you on that one, Jim?
Oh, an easy one to start with then.
An easy one to start.
I think you have to do it incrementally. So and carve out some protected time. The thing I realised is that actually if I could spend all my time dealing with crises, I could spend all my time just doing immediate crises and immediate problems, or I could decide deliberately to protect some time to do systems approaches, and that's what I did. Mm-hmm. So you allocate time to manage the crises and you allocate time to do the systems work. And maybe the best place to start is actually analysing why the crises come up so often and where they come from and what you could do about it. And a good example is Section 136, admissions for mental health problems in police situations. If you actually take a root cause analysis approach to that, or a systems approach, you can identify places where you intervene. And since we put a triage car in place in Hertfordshire for mental health, our Section 136 referrals for place of safety orders for people with mental health problems has dropped. So systems approaches can be used, if you use them well, to stop crises.
Anything you'd like to add, Harry?
Well, I'm not just because of what Jim said. I'm always wary to say what people in local authorities should do. It's not my job. But my experience is that systems thinking, allowing oneself to step back and look at the big picture, can help to see why some of these things are happening. Yeah. It's the age-old, the old story. Mike Kelly told it to me first about the person who's fishing people out of the river. There's loads of drowning people. Where are all these people coming from? We've got to rescue them. We've got to rescue them. And then someone looks upstream and finds some idiot pushing them all off a bridge. If you move upstream, you can stop some of the downstream crises happening. That's one thing. So I personally, when I'm faced with those kinds of challenges, I like to go back and map it out. What's going on here? I think the time dimension is also really important. Big problems, and the one I've dealt with most is obesity, are not going to be solved overnight. No. There are hundreds of different things that need to be done over decades, probably. We shouldn't beat ourselves up that we're not doing them all in year one. And taking the big picture view, not just in terms of the system, but also the time dimension, I think allows us to see that and be realistic about what one can do at any one point in time. I suppose the next step from that is really to think through how a system response might look if we're trying to phase things in terms of timing, which is why if you go back to the slide I showed that had political mandate at the bottom, there are quite a lot of actions that won't happen until the public and media discourse around obesity switches from being one of individual level blaming, conceptualizing it as a failure of willpower at the individual level, to understanding that obesity is the product of a whole load of market failures and other things that require upstream responses. So I think there are different ways in which a systems approach, grappling with the complexity of it, can help us to see beyond those crises, some of which clearly you still have to deal with, but you might stop some of them happening, maybe not now, but in a year or two's time.
Great. Now, a couple of questions are coming in on the sort of practical, how do you show that leadership that you talked about, Jim? For example, how can you implement, what are the implications of what you've described for people who work in complex systems in terms of leading change? And what examples do you have about how they can develop relevant knowledge, skills and behaviours to effectively lead change?
Okay. What do we know about the psychology of leadership? It's a set of influencing tools and mechanisms. That's essentially leadership in one sentence. And different tools and mechanisms work in different situations. So let's start with that first principle. And I think you can draw a roadmap, or a roadmap with various bits on it. So the first thing is identify what it is you're trying to achieve, and then start to win hearts and minds to do it. One of the things we did to win hearts and minds is we had you up talking to, I think, 3/4 of our elected members, and people still talk about that seminar. And then articulate what different and good looks like, build alliances, and start working with people. I think there's a big world of difference between the transactional leadership styles we've all been taught, which we do need, kind of management process, and this being comfortable with leading with complexity. So the leadership programme for the next generation of future public sector directors is trying to do that. But I think if you're going to be a leader in a systems approach, you need to be able to think systems, you need to be able to think influence, you need to have a repertoire of different tools, you need to be adaptive, you need to behave like a host, and I think you also need to actually bring people together. Now, the model of leadership that's flavour of the month is transformational leadership. The problem with that is it tends to be very kind of hero leader out there kind of pushing ahead. Well, the one thing that makes a good leader is followers, I've always thought. So I don't think this is a transformational tool. I think this is using leadership as a way of bringing people, galvanising people and empowering them. We could probably do another webinar or a seminar on that, but it's a different tactic. George Binney's book, Living Leadership, I think is that what it's called. His book on leadership is a great text for this. And I think a book on change, which I will dig out, which was written by some of the Ashridge faculty, is great. That, I think, is it in a nutshell. Have I answered those questions?
Very, very helpful, thank you. We have also a rather broader challenge that systems thinking has been around for some time, and what's new about the approaches that you have outlined, and what difference will it make? Can I perhaps start you with that one, Harry? If you have any thoughts on
Yes.
where we've been and where we're moving to?
So I agree. These principles, these ideas are not new. There's nothing original about what I'm espousing here. But I think what we're seeing is a couple of things. One is, I think there's a growing recognition that, certainly in the academic sphere that I inhabit, the generation of research isn't helping as much as it might. There's plenty of good research going on, but there are also some problems that we're just not making enough progress on, and something needs to change. And I think that is helping to coalesce a number of different threads here that are coming through, where there might have been disparate groups talking about this, but actually we're now coming together. And we managed to get something published in The Lancet about complex systems thinking, which I don't think would have happened 5 years ago. So I think one is, I think there's a grouping of people who are now collaborating on this, which is really helpful. Secondly, we have some funders who understand that there is a problem here. The Health Foundation absolutely being at the vanguard, at the front of this. But not just the Health Foundation. Big funders get it. They know there's a set of problems here that mean they're going to have to change the way they do things. And, some of us are helping work out what that might look like. And it's going to take time, but I think we're getting there. And I think thirdly, and most importantly, people like me are talking to people like Jim. And you guys have been doing this in your sphere, we've been doing it in our sphere, and now actually we're getting together and trying to work out how to do it together, which I think benefits both of us, both groupings.
I think you're absolutely right. I think Harry's hit the nail on the head. There is a sea change. You can feel it going on. I would use the analogy of psychology. Psychology has been around forever. Have we used it well enough in public health? Well, no, I don't think we have. I don't think we've used most of what psychology can offer us well. So the time is now to actually seize what it can bring and use it.
Another question that's come in touches on the fact that, of course, what happens at local level is in the context of national policy setting. So if there was one activity or approach that national policymakers could add in or change to the policymaking process to better consider complexity, what might that be?
I'm tempted to say get out of our way and let us get on with it at a local level, but I haven't said that, have I? I think it's break down the sealed policy making system we still have at national level, where what one department, the Department of Health, doesn't affect the Department for Education or others. Central government is, I think, the worst at joining up. And that's why I think we find it at local level more difficult to join up, because the way policies are written is they're siloed.
Any observations?
There was a great piece in the Financial Times today by David Allen Green, in which he was saying that underpinning many of the political problems we're facing at the moment is an overwhelming desire for easy answers to complex problems. And I think somehow getting over this idea that complex problems can be solved with a series of 2-hour meetings is essential. Now, that's easier said than done. And I think this comes back to the point I made about what's backstage and what's front of house. I completely sympathise with politicians who've got thousands of things going on, and they don't want to get involved in difficult, knotty discussions about complex adaptive systems. We shouldn't expect them to have to. If they want to, that's fantastic. But the job of people advising policymakers and decision makers is to distill that stuff out. And this is where I come back to the 20-year vision, 5-year strategy, 1-year plan. We can have our 20-year vision, but we've got to work out what makes sense within the political cycle and what makes sense now for this policymaker or decision maker to do now. And if he or she wants to step backstage and get involved in those knotty discussions, they're welcome. I'd love it if they were there. But I understand that it's not their job to be there. It's our job to distill these things out and present them so that they make sense, not just for what you do now as your next step, but where you're heading in the long run. One of the analogies I like is the difference between drafts and chess. All too often, we end up playing drafts. We say, what's the next move? What's the next move? What's the next move? Whereas someone who's good at chess, I'm terrible, but if you're good at chess, you're looking 20 moves ahead. You've got a strategy. You know you will get thwarted on the way there. Your opponent will move some pieces that you weren't expecting. You'll have to adapt your strategy. But you've still got your eye on the end game, rather than the next step.
Thank you very much. Now, we're also getting some more questions coming in, picking up on what you were describing, Jim, about how to actually support the use of complex systems thinking in local government. And the question here is, what are the top things that can be done to build local public health systems thinking capacity?
Oh, well, I think there's probably several. The first thing is get in a room and do some shared learning together about it. So perhaps take some... We've actually got a new website being set up, a blog site called Systems Approaches in Public Health, and there's some reading listed there. That would be my first step, is sit down and work out together in a room what it is you think it is. Perhaps do a training morning on it. We could run some of those if you wanted. The second thing, I think, is pick a problem and start to analyse the problem using network analysis, I would say, would be the easy way in. And then look at the range of factors and work out what you could do about them. And then I think the third thing is don't go running off to senior managers and elected members saying you need to do complex approaches. This stuff is a slow burn. Prepare your powder, get your argument, get your soundbite, build your case, and then win hearts and minds. So prepare it internally first.
Okay. I think we might have time for one or two more questions. This is an interesting one. It says the public are a key part of the system. How can you ensure that they have a full and active role as equal participants?
Well, I don't think we do that well as policy at present. So, how well do we engage patients, public? I think there's several mechanisms. One is, for me, elected representative democracy. Councillors are there to represent the public. Whether you think they do that effectively or not is irrelevant, because the law says they're there to do that. So you have to engage with elected members, and you have to turn elected members into champions for what you want to do and engage them. So make elected members your allies in understanding what the public want. I think secondly, be very transparent, have conversations with the public, listen to people, take opportunities to engage with as many agencies as possible, and take a diverse approach to doing it. So if you're consulting, for example, on changing public health nursing for children, well, you'll have a different group of the public that you want to talk to than if you're talking about changing a cycle lane. Try and engage them all and build it into the plan. And use social marketing, that helps. And be prepared to go out and use shoe leather and walk about. So last week, I went into some of our vape shops in Hertfordshire to say hello to the shops and say, okay, so what do you think about our smoking service and how could we work with you? That kind of thing. So I think it is just be purposive and do it. There's no single systematic answer to this.
Thank you.
Yeah, I think I'd echo that. Again, my first point would say I'm not sure I'm the right person to answer that question. But in as much as I can, I think those of us in public health, first of all, need to develop our skills in this area so we know how to do it ourselves. We should walk the talk. We should do it ourselves. We should explain what we're doing. And I also think we need to be humble and not assume that we've got the answers for other people. We need to go and talk to the public in all the many different meanings that can have. There's some really interesting work going on in Amsterdam at the moment. It's been going on for a few years to tackle childhood obesity, particularly inequalities in childhood obesity in Amsterdam. And I'm going there next week to find out more. But the overwhelming impression I get of the reason that they've had the success they've had is they've not gone out and told people what they need to do. They've gone out and worked with people in deprived communities and found out what makes sense to them. So I think we need to be much more humble in public health and much more engaged and do some shoe leather work.
Shoe leather work. Well, I think that's a good note for us to wrap up on. That is all the time that we have for questions, and thanks to everybody who has sent them in. I'm very sorry if we've, due to limited time, not been able to reach all of the questions that you have sent. But it remains for me, I think, to give a very big thank you on everyone's behalf to Harry and Jim for sharing your experiences with us and for your thoughtful discussion on the issues that were raised. So a big virtual hand clap to Jim and to Harry. And a huge thank you to everyone who has joined us today. I think we all found it a really stimulating discussion. This webinar will be on the Health Foundation's website in a few weeks' time. So if you've enjoyed the session and you'd either like to view it again or to suggest to colleagues that they might like to look at it, do visit our website over the coming weeks. And if you'd like to find out more about upcoming webinars from the Health Foundation, please also have a look at our website at www.health.org.uk. Thank you very much and goodbye.
Thank you.
Thank you.
Thank you. Bye.
Thanks for watching.